Hi, everybody. Good morning or good afternoon. I see that there are people starting to join, which is great. We'll give everybody a couple of minutes here to get into the webinar, and then we'll go ahead and get started at 12:01. Hi, everyone. For those who just joined, we're going to get started in a minute. I guess it's 12:01, so we'll go ahead and get started. Thank you for joining today. I just want to make sure that everyone can hear and see me. So if you can go to your React button at the bottom of your screen and give me a thumbs up or any emoji, really, to make sure that everyone is able to hear, that would be great. I see a thumbs up. Awesome. Thank you for sending that thumbs up in. Well, my name's Dr. Ern Chen, and I will be talking about health insurance plans today. Thank you for joining. And I have an introduction that we read at the beginning of every webinar. And our program, right, is part of the Advanced Clinical Training webinar series, where we share educational resources to support you in your healthcare journey. You should have access to the chat and the question and answer box. I'll be monitoring those as we go along today. Feel free to drop your questions and comments in the chat, and I can answer them as we go through. You do not need to save them till the end. This is a casual presentation. Feel free to chime in as we go here. There are not any materials to download, but be on the lookout for the recording after we're done today. And also that will come with a discount code to enroll in our programs if you are new to ACT. So thank you again for joining today. And I will now share my screen and we will go ahead and get started. Here we go. Let's see. Great. And we'll go to presentation mode. Wonderful. All right. Well, as we mentioned earlier, we're going to talk about understanding health insurance plans today. And what I love about this talk is obviously it's very relevant to you and your patients or future patients in terms of patient care. However, you may also find that this is personally relevant to you as you navigate understanding health plans and choosing benefits as you go through your employment career. So we'll go ahead and get started. And I will say that, why are we talking about this, right? I think the really obvious reason is that insurance directly impacts the types of care that patients get, how much it costs. And therefore, as a healthcare provider, you'll want to understand how your patients are engaging with their insurance and how their insurance is affecting their decision making, what types of treatments they want to get access to, what they have to pay for it. All of those things factor into what types of treatment patients will get. So understanding that will help you as a healthcare provider treat and manage your patients and their conditions. Across the country, about half of all Americans get insurance through through their employers, and about a third get their insurance through government programs, which are Medicare and Medicaid. And the rest, which is about 15%, is they're either getting their own insurance through the marketplace or they are uninsured. I see somebody put in the chat. Can anyone hear the audio? So let's do this again. If you can still hear me, please send a thumbs up or any other emoji for that matter through their reaction. Okay, I see some thumbs up. So Amara, maybe you need to turn up the volume on on your audio side, if you can do that, please. And the last thing that on this slide, but we're going to spend a whole slide talking about this, is we're really going to talk about the key insurance terms because these are very, very confusing. Terms like premium, deductible, copay, coinsurance. I mean, there are five very important terms and they all mean something completely different. And so we're going to spend some time going over that because these cause a lot of confusion for a lot of people. So let's keep going here. Okay, so as promised, here are the terms. So a premium, right? Premium is like any insurance premium, your car insurance premium, your renter's insurance premium, right? That is how much you pay either a month or a year to the insurance company to make sure you have insurance. Okay, so if you get your health insurance through an employer, they're usually taking it out of your paycheck every other week or sometimes every month, depending on when you get your paycheck. For people who aren't getting it through their employer and they're paying for it, they have to write a check or pay for it on a credit card or out of their bank account, every so often, depending on what the plan has asked for. So that is the premium. That's something that you pay to make sure you have insurance. A deductible is how much you have to pay before the insurance plan kicks in to take care of some of the cost. So you'll hear this also in car insurance, right? But it is depending on how much you have for a deductible. For some plans, it's $500. Some plans, it's $2,000. Some plans, it can be as high as $10,000. But that is how much you have to put in and pay healthcare providers, emergency rooms, hospitals. You have to pay that amount before the insurance will kick in. So that's what a deductible is. A copay is a fixed amount that is predetermined by the health insurance company. And it is the amount you will pay if you go see a specialist or your primary care doctor, or if you go to the emergency room or to an urgent care. These are all amounts that you usually know ahead of time before you take on the insurance. You'll know, oh, every time I go see the doctor, it's $50. If I go to the urgent care, it's $100, right? And then I'm just making up numbers here. The numbers will change depending on the insurance plan and what your benefit is. But that's a fixed amount. And that copay goes toward the deductible. So those two things are different terms, but the copay amount can absolutely go toward your deductible. Now, coinsurance is yet something different again. And coinsurance is how much you are responsible for after the deductible is met. So, for example, if a coinsurance is 20%, right, that means that after you meet your deductible, any expenses beyond that, you are still on the hook for 20% of those expenses. So it's not like once you meet your deductible, you're done and the insurance plan kicks in 100%. You still have some fraction of the bill to pay after that. And again, those coinsurance percentages can be very different across different plans. Out-of-pocket maximum is how much you have to pay in a year before the insurance plan will just take care of everything, right? So your coinsurance will add toward your out-of-pocket maximum, but once you hit that maximum, which you should know at the beginning when you sign up for that plan, they will tell you your out-of-pocket maximum is $10,000 or $20,000. What will happen is that after you hit that total the total out-of-pocket maximum, then the insurance plan will take care of everything. So these are all the five, or I shouldn't say all, but five of the very important health insurance terms that you will hear that are generally very confusing to people, including to healthcare providers. All right, so we're going to keep going here. So there are five types of plans that we're going to cover today: HMO, PPO, high deductible health plan, Medicare, and Medicaid. And we're going to go over these at a very, very high level, so that you get a just a very high level understanding of what these plans are. And again, the actual details and the benefits will be different for every plan. And so not all HMO plans have the same benefits. Not all PPO plans have the same benefits. But the HMO, PPO, all these 5 different ones have a certain structure to them that are important, right? That's important for healthcare providers to understand so that we can best take care of our patients. So HMO stands for Health Maintenance Organization, right? And what they are is they typically are a narrower network, meaning they have a very well-defined network of physicians, hospitals, clinics that their insured members can go to. And if you go outside of this network, either the plan will not cover it at all, or they cover very little and you end up being held accountable for a lot of the cost. So an HMO organization, a health maintenance organization, the real concept is that there's a well-defined group of healthcare providers that serve the insured patients. And in an HMO, you have to have a primary care doctor, right? The whole purpose of an HMO is for the primary care doctors to have really good control over the member's health and be able to make sure that the insured patients are getting the right care from the right doctors within the network. The primary care doc therefore acts as the gatekeeper to all access to other specialists. So, for example, if you have some knee pain and you want to see an orthopedic surgeon, within an HMO, you've got to get your primary care doctor to make a referral. And typically that means you have to go see your primary care doctor. They have to examine you. They have to make sure they're not someone who can handle it, or if they try to manage your knee pain and it doesn't get better, then they have to be the ones to send you on to an orthopedic surgeon, or a physical therapist or any other specialist. You can't just call an orthopedic surgeon's office and book yourself an appointment. Within an HMO, that would not be approved. So again, HMO, just think of it as a very well-defined network of doctors where the primary care doctor, every insured patient has one. Your primary care doctor is the one who allows you to see any other specialists. So that's an HMO. A PPO is a preferred provider organization, and it typically has a much broader range of doctors in the group. And so typically patients who have a PPO insurance can choose almost any doctor anywhere. They're still in network and out of network, but the network is much, much larger. And they don't have to have a referral from their primary care doctor. So if you have a knee pain example, right, and you're a PPO patient, you can call your favorite orthopedic surgeon and book yourself an appointment in there. You do not need your primary care doctor to see you first or to make that referral. Those are the main clinical access differences between HMO and PPO. Now, there's usually a big difference in how much you pay for these insurance plans. So an HMO is typically a lower premium. You pay less for HMO insurance than you pay for PPO insurance. And it's just basically because your choice is restricted in an HMO plan, you pay less. If you want choice, you pay more. That's one very, very simple way to think about it. And so those are the kind of the key differences. As we walk through this presentation, we'll have another example in the second half of the presentation where we talk about a patient who has back pain, and we walk through what their patient journey looks like depending on what type of insurance they have. So that will be another place where we kind of illustrate what's the difference between HMO and PPO plans. All right, the third type of commercial health plan, right? And commercial is not government, right? Commercial is typically through your employer or your spouse's employer, and can be purchased through that. So a high deductible health plan is actually exactly that. It's a high deductible health plan. Now, these typically are the cheapest to buy, right? So your monthly premium for a high deductible health plan is usually the lowest of all three, HMO, PPO, and high deductible. However, the high deductible plan can be the most expensive overall plan if you end up accessing the healthcare system. And again, we'll have an example very clearly of this. But as you can see down on the bottom, we talked about what is a deductible earlier on in a couple of slides ago. And the deductible for a single person can be as high as $7,000. And again, the deductible means you have to hit this amount and pay this amount before the plan kicks in, right? So you have to fork out $7,000 before the plan kicks in. Or for a family, that could be up to $14,000 or $15,000. So this is a great plan for people who are not expecting any healthcare expenses. If they're healthy, and typically never need to see a doctor, never need to go to an emergency room, they're just kind of healthy people. They like this plan because it is the cheapest one. However, if something happens and you end up needing to go to hospital, emergency room, get surgery. This is where the high deductible literally kicks in, and it can be very, very costly to pay those bills before the insurance will kick in. So here's an example. So let's say you've got a family on a high deductible health plan. You'll see in the table, right, the deductible for this family is $8,500. This is merely an example, right? Their monthly premium is $800. So they have to pay $800 to the insurance company every month just to have insurance, right? Their child gets strep throat and goes to the ER. They have to pay $150 for that visit. The full cost, the insurance is not covering any of this, right? Now, annual physicals and preventive care as part of their plan are covered, right? So they don't have to pay anything for preventive care, which is great. But their out-of-pocket maximum is $14,000. So if they go to the urgent care a few times, the ER a few times, they're paying for all of those visits until they hit $14,000. And so if you think about the uh, the premiums and in the bottom half there, their premium is $800 times 12 months, right? Which is almost $10,000. They're paying that just to have insurance. Their deductible is $8,500, so they have to pay the first $8,500 of what healthcare services they're getting. So now we're up to $18,000. Beyond that, they have to pay 20%, right? That's their co-insurance of all the bills until they hit the $14,000 maximum. So if you add all the numbers up, right, 9,600 plus 8,500 plus $14,000, right, you're basically at $32,000 before you're paid up and done, and the insurance covers everything else. That is extraordinarily hefty. And you'll see again through another example later on that if you're not expecting healthcare expenses, the high deductible plan is very expensive. And the other plans, your HMO and PPO plans, are actually overall going to be a lower cost for people who expect to interact with the healthcare system. So thinking about this for a second of, when you've got a patient in front of you, right, understanding what type of health plan they have absolutely will influence their decision and willingness to follow your clinical recommendations. So if you're telling them that they need a really expensive medication or very special antibiotic, right, that happens to cost a lot through their insurance plan, if they have a high deductible health plan, they may be less willing or interested to take that medication versus if they have an HMO PPO plan, which will cover a lot of the expense of their medication. Um, as you can tell, these are also plans that start in January and end in December. And so at the beginning of the year, nobody has hit their deductible or out-of-pocket maximum. So at the beginning of the year, sometimes people have more reticence to follow through with things. But once they hit all these numbers in the middle of the year and the insurance starts kicking in, people may then become more willing to follow through on the clinical recommendations because now the plan's going to cover a bigger chunk of it. So all of these dynamics and what do you call it? Uh, Costs, right, kind of play into how patients and families will look at recommendations and decide what they want to follow. Um, all right. So a high deductible health plan, right? Sounds great because the premium is lower. And when you're looking in a chart and the HMO plan costs this and the PPO plan costs that, and the high deductible health plan has the lowest cost associated with it, many people are attracted to that, right? So the premiums are lower, but if you end up using healthcare a lot, it can end up being more expensive overall. Typically, all these plans cover preventive care. So going to see your PCP once a year, getting your most basic preventive care like flu shots, those are usually free. Oftentimes things like mammograms are free. And I shouldn't say free because they're part of the plan, but they're not charged extra for it. And that goes for all the different plans. And however, if you do anything or if you go see any healthcare provider outside of preventive care, right, whether it's a specialist or an ER visit, you're going to pay the full cost of that, including for any blood tests or x-rays that are obtained in those settings. We're going to talk about HSAs shortly. So we'll come back to that because that can be its own discussion. We'll get to that. And the other thing is sometimes these high deductible health plans come with very narrow networks. And if you go outside of that network, the costs shoot up even higher. So, so it's important for your patients to understand, right, if they're in network seeing you or out of network and how much that's going to cost them. Now, overall, high deductible health plans make patients a lot more cost conscious because they're going to have to pay a hefty chunk for whatever they're choosing to do. And people, when you have to pay for it and it's a significant amount, you tend to think more carefully and deeply and ask more questions about what you are going to pay for. And you can then make a value decision of whether that is it's a good thing, a good idea to sign up for something or not. And patients typically think a lot more about that when they have to pay for it. Okay, so this is the slide where we talk about HSAs and FSAs. So I know it's kind of an alphabet soup, right? HMO, PPO, HDHP, FSA, HSA. It's very confusing, but my goal here is to make these as clear as possible to you. So the first thing to know is you can't have both. You can only have one or the other, an FSA or an HSA. Now, HSAs are paired with high deductible health plans. You cannot have an HSA unless you have a high deductible health plan. And if you have a high deductible health plan, you can only have an HSA, you cannot have an FSA. So, what FSAs are they can be paired with any health plan that's not a high deductible health plan, meaning an HMO or a PPO. Now, here's the thing. So HSA, you can have one when you enroll in a high deductible health plan. There's a limit to how much you can put in an HSA, which for this year is $4,300 for one person. And if you have a family on the plan, it's $8,550. Oftentimes, an employer will contribute to that amount. What's great about it is that the money that goes into it, the money you put into it, is not taxed, right? It goes in pre-tax. It grows tax-free, so it's, it's in an investment account and it can grow. And so whatever gains you get from the investment are not taxed. And when you take it out to use it, it's not taxed then either. So it's great if you can grow it, right? As you put money in, that money becomes available to use for healthcare expenses. And if you don't use what you put in that year, it rolls over to the next year. It's sort of like a healthcare bank account. And so you keep that money. It's your money and it rolls with you. If you leave your employer, you still have access to it. It's yours, right? And and what you can use it for is a huge range of expenses. All the copays and deductibles, you can use it for that. You can even use it for over-the-counter things like Band-Aids, Neosporin, antibiotic ointments, all kinds of healthcare expenses. You can use it for dental work, vision, glasses. It can be used for many, many things. And again, it's pre-tax money that goes in and you're not taxed on it. So some people call it a triple tax advantage account. And again, that you can only get one of these if you have a high deductible health plan. An FSA is a flexible spending account, or you'll hear people call it a flex account. A flex account, you would get through your employer, and again, you have to be in one of the HMO or PPO plans. You cannot be in a high deductible health plan, and the maximum you can put in a year. This year it's $3,300. It goes up by a little bit usually every year, but this year's maximum is $3,300. The money that goes into it is pre-tax, so you're not taxed on it. It doesn't grow over the year. What you put in, what you say you want to elect is what goes in. It does not get bigger. It also doesn't roll over year to year. So if you don't spend it this year, it's gone. Some plans will make an exception where they'll say, oh, it rolls over for 90 days into next year, things like that. But that's not uniform. So the best way to think about flex accounts are during the enrollment period, right? You think about how much you're expecting to spend on healthcare, again, including dental and vision, eyeglasses, prescription sunglasses, contact lenses, dental exams, crowns, root canals, all your doctor's visits. And then that's how much you can put into it, up to $3,300. If you don't use it, then it's gone next year. So that's the downside to a flexible spending account. And again, you can use it, like we talked about, for a huge range of expenses. Let me pause there because I've kind of given everyone a lot of information. The Q&A is open. If anyone has questions, please throw it in there. There's also a chat that's open that I'm monitoring. If anyone wants to throw any questions or comments in there, I'm happy to take them right now. I don't see anything coming in. So let me keep going, but please know that you can throw questions in at any time. Okay, so this is, if you're thinking of questions, this is a great slide to be talking about as you're thinking of questions. So eligible Medicare and Medicaid, yes, very shortly. So medical expenses, such as doctor's visits, copays, emergency room visits, urgent care, all of those things can be paid for using your flex account. We talked about dental, vision, and over-the-counter. Now, these things are important because if your patients have a flex spending account or an HSA, it is a reminder to them that they can use pre-tax dollars and the money that they've set aside in there to pay for some of the things that you're recommending for them. So this is critical. Okay, so for the person who asked about Medicare and Medicaid, we are going to talk about that now. Now, we can spend hours talking about Medicare and hours talking about Medicaid because they are complex and deep programs, but we're going to talk about them today at a pretty high level, so that you understand how Medicare and Medicaid are different from commercial plans. So Medicare, right, is a government insurance program. It is only for people who are 65 or older, or people with disabilities, or people with or on dialysis. Those are the only ways to qualify for Medicare. So if you're a healthy 59-year-old, you cannot get Medicare, right? You have to be 65 or older, disabled, or on dialysis. Medicare actually has several parts to it, and these parts can be purchased separately, or not purchased at all. So Part A, which most people, or if not everyone on Medicaid or Medicare, sorry, has, covers inpatient hospital stays, also covers skilled nursing facility or rehab, right? So if a patient ends up in the hospital and is then too weak to go home and needs to get some non-hospital skilled nursing, or go to rehab for some period of time, a couple of weeks before they are strong enough to go home, then Medicare Part A covers that. They have to have Medicare Part A coverage to cover that. It also will cover some home health care. Now, there is sometimes a misunderstanding that Medicare will cover everything, right? And that the patient pays nothing. The truth is, there is often a coinsurance with Medicare where patients are responsible for 20% of the hospital bill. As you all know, hospital bills can be very, very large, especially if you are sick, have lots of comorbidities, and end up in the hospital for a significant number of days. Hospital bills can easily run into several $100,000. So 20% of that is not insignificant. All right, so that's Part A coverage. Part B coverage, which you have to purchase separately, and as you know, as the slide says, there is a monthly premium associated with buying Part B insurance, and it's, you know, generally around $170 or around $200 is a way to think about it. It also comes with a deductible, and this covers doctor's visits, so non-hospital doctor visits, like going to see the cardiologist, right? It covers things like x-rays and labs. It covers some medical equipment like walkers and canes. So lots of different things go into Part B, but there is a deductible like all the other insurance plans that we've talked about. Part C, and you've probably heard about Part C, it's called Medicare Advantage. Now, Medicare Advantage plans are run by commercial insurance companies. So you'll hear about, you know, all the big name insurance companies can have their own Medicare Advantage plans, and they combine Part A and Part B benefits together with a single premium. So when someone goes and buys a Medicare Advantage plan, they're paying a single premium to that insurance company, and they get hospital coverage, they get coverage for doctor's visits, lab tests, x-rays. It's very much like the commercial insurance plans. Most Medicare Advantage plans also include vision and dental insurance. And so it's a very nice comprehensive plan for people on Medicare who want to kind of get all these benefits and can pay for it, right? Now, Part D is the drug coverage. It's medication coverage. So the vast majority of medications come under Part D, and in order to get Medicare to help cover your drug expenses, you have to buy Part D insurance. It's not free. But purchasing Part D insurance allows you to then get Medicare to partially cover your drugs. So again, as you can see from this, Medicare is not just one insurance plan. It's a complex web of different benefits, and there's different ways to piece them together. I put a website down on the bottom on Medicare Basics, which is actually a really good website with a lot of FAQs on it. So if you'd like to learn more, that's a great place to start. And I thought there were enough people asking about Medicare. That's why we put this whole insurance talk together, that you might be interested in viewing that webpage. So Medicare, not to be confused with Medicaid. So Medicaid also has eligibility criteria, which are different from Medicare, right? So remember, Medicare is people who are 65 or older, disabled, or on dialysis. Medicaid is based on income. So families or people with low income, and very specifically, right, they're usually 138%, sorry, below 138% of the federal poverty level. And the eligibility takes into account several things, right? One is the household income. Two is how much assets they have, right? So how much they have in their bank account. Do they own homes or cars, or what do they own, right? How many people there are in the household. All those things kind of get put together to determine if someone is eligible for Medicaid, right? So Medicaid is really a financial eligibility, if you will. Now, some people qualify for both Medicare and Medicaid. And what that means, and you'll hear the term dual eligible, right? So a dual eligible means that they can have Medicare and Medicaid together, and that they get the benefits of both. Now, Medicaid is administered by the states. Medicare is administered by the government, right? So Medicare is kind of uniform across the whole country. Medicaid differs by the state. So the state funds their Medicare programs by a combination of state money and federal money coming together. Now, it's not necessarily 50-50. The federal government funds Medicaid depending on how wealthy or poor the state is. So depending on the state, the federal government may give more or less to that state, and the overall Medicaid program may be funded 60-40, 40-60, 50-50, 30-70, right? It just depends on how wealthy, if you will, that state is, and that will determine how much they get from the federal government. People have to apply, right? Because there are some income-based eligibility, financial eligibility criteria. People have to apply for Medicaid in every state. And there are social workers, caseworkers who help with those applications. And then, when a determination is made, they will help the families get access to care. Now, Medicaid, because it's partially funded by the states and by the federal government, the benefits that a Medicaid member has can differ from state to state, because the states can decide what benefits they want to give their Medicaid members. There will be some things that the federal government dictates have to be covered in every state, but beyond the few things that are mandatory, the states can choose what things to cover and how much to cover. So if you live on the border between two states, right, you may get services and get coverage for certain things on the side you live, but if you moved over to the other state, those things may no longer get covered. So it's actually interesting to the point that sometimes families will move states just to get certain benefits that their children need or that they need that are not covered in the state where they live. So that is an interesting thing. So if you have a patient that's, moving, who has Medicaid, that's something that you really want the family to think through and that you can help with to make sure that they are going to get access to the same services or better services when they move. Medicaid, right? Because the income level of the people on Medicaid are generally very low. There is very little cost sharing. So people on Medicaid pay very, very little for copays or coinsurance, if anything at all. So that's Medicaid. So there are a lot of words on this slide. We're just going to go through the arrows on the top. But as we've talked about, right, the type of insurance that your patients have can absolutely impact how you create a care plan for them and how you work with them to get the care that they need. It allows you to have a educated, reasonable discussion with them about cost. And if insurance has to approve certain treatments or medications that you're ordering or referring a patient for, there's a whole workflow that needs to be accessed and performed. And so being familiar with that, or having people in your office, even if it's not you, but people in your office who know how to do that for your patients, is very, very important. And then sometimes what you ask for is not approved by the insurance company, and the insurance companies have an appeal process. So for all healthcare providers, knowing how to navigate that process is very important for our patients. So as I promised, we're going to walk through a patient experience, right? So we're going to take a single patient and walk through these different types of insurance to see how their patient journey, their care journey would look if they have these different insurances. So our patient today is John. John doesn't have an age here because I want him to be also eligible for Medicare, as well as the commercial plan. So just think of John as someone who's experiencing chronic lower back pain. And he, needs to see his primary care doc. He probably needs an MRI. He needs to see a back specialist, an orthopedic surgeon or spine surgeon. He needs some PT and pain medication, right? So this back pain's really been bothering him. And this is just a single slide to show with the different types of plans, how someone like John, how much they would end up paying for all the things that we just talked about, right? Doctor's visit, specialist visit, imaging, and PT and medication. So on an HMO plan, right, he would end up paying about $665. Remember, HMO is a narrower network, and your PCP has to be the gatekeeper to any additional services that you need. PPO plan, right? You've got more choice, but it's more expensive. High deductible health plan is high deductible, so you're gonna pay all the way till your deductible is hit, which in this case maybe $7,000 before the plan starts kicking in. A Medicare patient, a Medicare John, would end up paying about $2,000, so around what a PPO, or maybe slightly more than that. And Medicaid, right? Again, Medicaid eligibility is determined by financial circumstances, and they would pay very, very little to get this. Now, these are the cost differences. There are also access differences and timeline differences. So let's go through those now. So with an HMO, it would probably take John about 6 weeks to get through the whole gauntlet, right? So in week one, he's going to go to his family doctor, his primary care doctor, with a $20 copay and say, wow, doc, this back pain's killing me. I need some help here. And the primary care doctor is going to see him and say, you know what? I agree with you. Let's send you to a spine surgeon. And so he will go and see a spine surgeon, which he can probably get in within a week, right? And he would get the spine surgeon would see him and say, you know what? Let's get an MRI just to make sure there's nothing we need to do surgery on. So off he goes to get an MRI, and that's $100 copay. So he's paying that. And then he comes back after the MRI to see his orthopedic surgeon, pays him $35 there to see the orthopedic surgeon. Surgeon says, oh yeah, I looked at your MRI. I don't see anything on there that I need to do surgery. I think you need to go do PT. So he makes a referral to PT. And part of that is getting the insurance to authorize John getting PT. And then he gets to PT and he gets his therapy. He pays $25 every time he goes to therapy. That's his therapy copay. And he also gets a prescription for pain medication from his primary care doc, and he's filling that, and it costs him $10 a month. And so it takes him about 6 weeks to go through this whole journey. Once you add up all the PT costs and the medication costs and how much it took to see everybody and get an MRI, it's about $600 to $700. So that's the HMO experience, right? Took about 6 weeks. This is typically about as fast as it can get in this day and age. Now, PPO, right, can get faster. This is a little more expensive. But because you've got a broader network of doctors and more choices, right? Typically, patients can get through more quickly. So you don't need to see your PCP first, right? So you skip that first visit and you can go straight to a specialist if you'd like. If you see your PCP, that's okay too. And then you end up seeing your specialist. You can choose any imaging center to get your MRI, and you choose the one that's got no wait list, right? You get the MRI, it's going to cost you a little bit more than the HMO plan. So it's going to, in this case, we'll say it was a $250 copay for the MRI. The orthopedic surgeon looks at the MRI and says, you need to go to PT. PT sessions in a PPO plan are going to cost more too. They're now $40 a visit versus $25 in the previous example. Every time you go, it's $40. Pain medication, right? In this case, it's $15 a month as opposed to $10 a month in the previous plan. And because you've got a broad network available to you, you can choose your physical therapist that has no wait time. So it is quicker to get through this, but it also costs more. Your premium costs more, and all the copays are a little bit higher than the HMO plan. So this is the difference between HMO and PPO. Now, a high deductible health plan, right, can be HMO or PPO, and the timeline would be based on HMO or PPO. However, the amount that a patient pays in a high deductible health plan will be significantly more because they have to pay their entire deductible before the insurance will pay anything, right? So either of the timelines before that we just showed apply. The thing that is different is that John will hit his $7,000 deductible. He's going to pay $7,000 before the insurance kicks in. And then after that, he's still responsible for 20% coinsurance. So 20% of all the bills coming in after $7,000, John's still going to have to pay that. So he can use his HSA for it if he would like. Remember, that's the pre-tax savings account. He can use that, or he can pay for it, not using the HSA account, to let his HSA account grow. So that's up to John. Again, remember, right, the HSA and FSA accounts will cover the doctor's fees, hospital fees, x-ray fees, any equipment, splints, braces that are prescribed, PT, OT, some of the transportation, if it's medical transportation, that will cover it. And then over-the-counter items, many of them will be covered as well. So these flex spending accounts and HSAs can be used to cover some of these expenses. But again, remember, you can only put in $3,300 into a flex spending account every year. So that can disappear pretty quickly if you're seeing doctors. Now, Medicare, the timeline is similar to a PPO. unless you live in an area where there are not very many Medicare providers. So not every doctor takes Medicare insurance, right? And one of the reasons for that is Medicare reimbursement rates are different from commercial reimbursement rates. And so there are fewer doctors, or I would just say not everyone in any given community will take Medicare insurance. And so that may limit how quickly someone can get in. And just remembering from Medicare, right, you don't need necessarily to have a PCP to refer you. You can go straight to a specialist. So John can go straight to an orthopedic surgeon if he wants. But again, that orthopedic surgeon must accept Medicare. And then there are deductibles associated with Medicare, right, and coinsurance as well. So that can be pretty hefty, right? And a back pain episode that we have outlined can reach up to $2,000 or so for John. So just being on Medicare doesn't mean that it's cost-free. There are certainly costs associated with getting care with Medicare insurance as well. Now, Medicaid will cost very, very little. However, there are even fewer doctors who take Medicaid insurance. And so the timeline to get into seeing a primary care doctor and then a back specialist and then physical therapy, right? That's all very long and drawn out because there are fewer providers to see Medicaid patients. And so the wait lists are longer. So all the different steps can still happen, but it could take many, many months instead of just a few weeks. So that's the difference. So overall, right, we think about, well, what are the differences between Medicare, Medicaid, PPO, HMO, HDHP? The real differences are these four things, right? So how quickly can you get in, right? And that's really determined by how many providers there are who take that type of insurance. There are out-of-pocket costs. So how much is it going to cost the patient? And remember, you've got to add in the premium, but also all the copays and you know what the deductible is and what the max out-of-pocket is. That's kind of your total out-of-pocket costs. Provider choice. So lots of people are available to a patient who has a PPO plan, right? But if you have an HMO plan, that pool narrows, and Medicaid, it's an even smaller pool. And also each plan will have very different authorization requirements. And we just heard that, you know, just PPO, basically patients get to choose virtually where they go. However, HMO plans and Medicaid plans are much, much more restrictive. I see a question. Sorry, this may have been slow for me to get to. In medical school, is the topic of insurance and different plans covered in depth, or is it something that students are expected to understand on their own time? That's a really good question. So, very few medical schools talk about insurance and teach students about insurance. This is something that students are really, you know, pick up when they're doing their clinical rotations. If this is something that is of interest to you, which I would encourage all of you to really understand this for the sake of your patients. The people who truly understand how these plans work really well are the social workers and the case managers that are helping to take care of the patients on the wards. And so those are the people to talk to. Physicians in general don't understand insurance very well. And part of it is by design in the sense that physicians don't make clinical choices and determinations based on insurance plan, right? You don't want to say, oh, if you have Medicaid, I'm only going to prescribe you this, but if you have HMO insurance, I'm going to recommend all these other things, right? Physicians will make recommendations on care and perform clinical care based on patient clinical need. Now, where insurance comes in is in the fine tuning, right? Of, well, on your plan, this antibiotic is $5 and that antibiotic is $15. So which one, does it make more sense for you, right? Or on your plan, right, this antihypertensive costs the same as these two. So do we want two separate ones or one single one, right? And there's the fine tuning should be based on insurance. We don't. As a rule, we do not make different recommendations for care based on insurance. But the fine-tuning pieces, right, of understanding how cost impacts the patient and how to get them what they need. Oftentimes we partner with social workers and case managers to make sure that the patients are able to access what they need. But this is not generally a topic that is covered in the formal medical school curriculum. There are some schools that have a business of medicine course that they teach, but insurance is not often an in-depth topic at all. Okay, sorry, there's another question. Based on what I understood, HSAs are only available under a high deductible health plan. Is there a different way to gain access to an HSA? There may be some standalone HSAs. I am not familiar with those, but there may be some standalone HSAs. The most common way to get an HSA is when it is paired with a high deductible health plan. So I hope that answers your question. This is our last slide. So again, right, understanding how insurance is structured, how it works, how people, meet deductibles and coinsurance and all these things will help you understand how your patients are thinking, and help them understand what they're going to have to pay for so that you can fine tune and tailor your clinical actions for them so they get what they need. You can also help them navigate their insurance requirements and help them understand their coverage so that they're not surprised, right, by the bills that they're getting. It will also allow you to help them with how to get the most for their dollar. And again, that will differ from plan to plan and from patient to patient, but being familiar with their plan details. And again, doctors are often not doing this alone, right? We are doing this with social workers. Now, oftentimes for complex patients, they have case managers with the insurance company to help and assist as well. And to your questions about these all these different types of insurance and what benefits come with them. Sometimes what benefits come are dictated by government regulations, and that can change over time. So staying in touch and up to date with what's happening in the world of insurance and health insurance is very important if you want to be able to help your patients in this way. I'm pretty sure that is my last slide. So I'm happy to take any more questions. Oh, I see questions coming in. Okay, what is the process of verifying insurance and checking for referrals for patients in your clinic? Okay, so typically when a patient comes in and checks in, they bring their insurance card. And a lot of places have an automated way of scanning that in and performing a check to make sure the card is, the information on the card is legitimate and real, and that information, their insurance member number and the plan type, those in the system will show what benefits the patient has and what their copay for the visit is. So oftentimes it's not a clinician, right? It's the front desk receptionist or clerk who's doing these checks. And then in terms of referrals, oftentimes if you determine as a clinician that you want to refer your patient to a specialist, that can either be done depending on where you are and what the system is. You can put that through in the computer, and other times, a phone call has to be made to the insurance company to get approval. So there's two different ways of doing that, and that may and it just depends on where you are, what your computer system is, whether it's connected to or how your insurance companies want to handle that communication. From your experience as a provider, was there ever a time where a patient's insurance plan affected the way you wanted to help them? I would say no. I have always treated my patients based on clinical need. Now, sometimes what will happen is the social worker or case manager may come up to me after I've made a recommendation and say, it's going to be really hard for this patient to blah, 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 whatever it was, right? And that's when I would work with the social worker to say, okay, well, this is what they need. So let's figure out how to get it to them. So instead of ordering it once a week for 4 weeks, can we just order all of it as a one-time upfront so they get everything and then leave it to the family to portion things out for 4 weeks, right? Because they cannot order it more than twice or something like that. So there's ways to work the system, not cheat the system, but work the system, right? But at the end of the day, it is trying to figure out how to get the patients what they need. And I've always been able to figure out a way, fortunately for my patients. And again, not by myself, right? With the rest of the team of social workers and case managers, and who are usually nurses. Let's see. A last question here. Whenever you are about to meet with a patient, do you always keep their specific insurance plan in mind to tailor your approach? Actually, I never look at their insurance, unless it becomes a problem, right? Or unless I know it can become a problem. So what that means is I approach my patients purely as a clinical relationship. If my recommendation is something that I believe is going to be challenging or could be challenging depending on insurance, what I would tell the patient is, well, my recommendation, right, based on what you have is this, and I would explain why. And then I would say, well, let's go check, right, with the, social worker, case manager, insurance, whatever it is, right, to see if how much it's going to cost you is going to work. And you know what? Oftentimes it is. And if it's not, then let's come back and rethink how we want to do this, right? But at the end of the day, your blood pressure is too high, or you really need to get this blood test, or we really have to check this, right? And let's figure out a way together to get you to that. And again, you're right. Usually it's possible. It just takes some effort and energy. So we're past time here. Thank you so much for joining today. I've loved the questions, and you will get a recording of today's webinar. It will also come with a discount code to enroll in ACT's programs. I look forward to seeing you in your healthcare journey in the future. Thank you very much. Bye-bye.